Stephen. I really appreciate the invite and a chance to just reflect a bit on what I've seen and what we have been through as a community, impacting us in a tremendous way with COVID. I started to give this conversation with you all in my sanctuary today. I was going to impress you. I was going to have a background with stained glass windows and pews and red and just great color. And then I said, well, why do that? Let me invite them into my real sanctuary. This is where we've been since February, in my living room over Zoom, because it just isn't safe to bring people in my community or in any community for that matter into a room together. My church is in a zip code 21215, which won't mean much to many of you, but in Baltimore, it's Death Valley for COVID. It's the place with one of the highest rates in terms of contracting COVID and those who disproportionately die from COVID. We've learned an awful lot over the past several months. And one of the things that I've had a chance to do is conduct focus groups for Johns Hopkins University and Robert Wood Johnson to bring pharmaceutical companies like Pfizer and Sanofi in to talk to my congregation and dispel rumors and misnomers. And conducting those focus groups, the amazing thing that I've learned that has kept me awake at night is that for many African Americans, they distrust and dislike the research and healthcare system so much in this country that they'd rather die than take a vaccine that many of you would offer. And even though they're seeing celebrities and politicians and others take it, and God knows Hank Aaron's death didn't help, many of them are still in that place. They've learned that we're connected. I've heard them say again and again that the only reason folks are asking us questions about our health and vaccine hesitancy is all because they realize our health is connected to theirs. That before this, TERRIS, no one was concerned about how well we were doing or how badly we were doing. But now all of a sudden they're interested in our thoughts. I can't do anything but agree with them and keep bringing them facts as best I can. But in the midst of that, we've come out with something else as we talk to various groups across the country, just a little small church trying to do its part. We've come out with a sense that if entities talking to us would talk about more than vaccine hesitancy, if healthcare institutions would also talk about the health issues and concerns that we had before COVID ever came, we might trust that they're actually meaning us good for when this is over. And we might actually listen to them in terms of taking a vaccine. And those doors have opened. And this is one of those doors, and I'm gladly stepping in it. I remember before COVID existed, we talked about things when I was in government. We talked about things like precision medicine. I remember those days when I was just excited by the thoughts of 2020 or 2030 or any light years into the future that we would have a day when medications would be described not just based on your disease type, but milligrams would be prescribed based on your genetic pool. Boy, I remember those conversations. with researchers when I was the deputy director of clinical quality and was in charge of the coverage decisions in that world. I remember those conversations that told me it was important that the variability of drugs was contributed by genetics. I remember talking about absorption rates. I remember talking about need for more African Americans and minorities to participate in clinical trials because there weren't enough, period, African Americans participating in those trials. I remember those conversations. And guess what? We still aren't willing to participate in clinical trials. And the progress that we were looking to make in terms of precision medicine, because we realized that there were certain hypertensive medicines that were having a different effect on African Americans. And this had happened with a number of drugs. And we're still facing those issues today. What COVID has taught me, not just with healthcare institutions and helping them develop interventions, but with researchers, we need each other. We need each other in terms of trials. We need each other in terms of participation. We need each other to move forward. We as a community need you to work with us to develop drugs that affect what I call the big three among African Americans: diabetes, hypertension, and even to some degree prostate cancer. Of course, obesity is an overarching thing that I don't believe you can take a pill for yet. But these are the kind of things that disproportionately impact our people. And here's a showstopper. Our people still don't know why we disproportionately die from COVID. I mean, it's crazy mixed message that works for some, but it doesn't work for me, that says it's social determinants. Well, I know social determinants is how many people live in a community, are there grocery stores, what's the air? I get that. But then they switch over and they want to start talking to me about diabetes. That's not a social determinant. The answer is you don't know. And finally, many scientists at the highest levels have admitted to me, TERRIS, not only don't we know, but it's obviously not a priority. Hey, here's something new to do to build trust. Let's make the health of African Americans a priority. Wow, that's a novel thought. Huh? I mean, let's actually care about Black bodies in the same way we do everyone else's. How about that? How about that? That will give me the inroads to maybe push people to want to participate in a clinical trial. If they think you, the people on this line, I'm not talking to some hypothetical people, if you actually show you care whether we live or die. Now, here's the key. Your rationale and reason for doing the things that I'm going to talk about next really doesn't matter. I don't care if you do it for the reasons of return on investment. That doesn't matter. Be transparent. It's okay with us. As long as we are helped. And you don't have to be empathetic. You can fake it. But as long as you are willing to help. I'm just trying to keep my people alive. And what I recognize, being a scientist and a pastor and a former healthcare executive, what I realize is we are talking two different languages. That's the problem. That's the problem. The problem in not being able to push more folks towards clinical trials is we are definitely looking at the wrong message and the wrong messengers. You need pastors like me, the trusted sources in communities. And they don't trust us just because we preach on Sunday. They trust us because they know we have a vested interest in keeping grandma alive. They trust us because we feed them, we shelter them, we care for them. And we don't need paternal outsiders coming in telling us how to run our community. What we need is for you to work with us and to respect our position. Here's what I suggest. I suggest we come up with a way to build some models and not just let this be a conversation today. Oh, I've had so many of these speeches, I can't tell you. I've done so many interviews all around the world. And for a moment, I felt popular. But my 15 minutes of fame, I could care less about. If I can save one Black body, all these speeches are worth something. Let's, after this, do some walking and not just talking. Let's build a human-centered design model of community-based participatory research that actually utilizes the sacred space that African Americans have. What is that? I used it when it came downtime in Baltimore to raise the vaccine levels first for the flu. And now the health commissioner in Baltimore has me using it for COVID. What's our sacred space? This is where we tell our secrets. It's in the sanctuary. It's in the beauty salon, and it's in barbershops. If you really want to get an African-American woman riled up like my wife, tell her she can't go to the beauty salon. That's where we talk about our fears, our faith, and moving forward. The best part of church service, everybody will tell you, is not the service. Child, it's what we talk about when the service is over. Utilize that space for what? Utilize that space so that we can work with the pharmaceutical industry, the researchers, to build programs where we become your marketers, where we are first convinced as pastors that what you're doing is for our benefit, that the drugs you're making, be completely transparent, are for our benefit, and then invest in our community. Hold it, let me stop. We don't work for free. Give us a stipend so that the warriors that I have in my congregation will begin the process of pulling others into clinical trials, pulling others into your research. What we discovered from COVID is we're connected. Let's use this process to connect and build processes that work for both parties. This is not novel. This is not new. We've done things like this before. There are folks on this line. I see your names, and I've done it with you. Things like Dolce, community-based, community health workers, community-based, the Memphis model, community-based. Come on, I've researched this stuff out the wazoo. It's happened everywhere. It's just a fact that some people don't want to do it. And we can do the same thing when it comes to clinical trials. Remember, the problem is not just the message, it's you as the messenger. So let me help you. After this call, let's do more than say, oh, Pastor King, that was really a nice talk. Oh, I felt goosebumps. Nobody cares about that. I'm trying to save Black people. I'm trying to save brown people. I'm trying to save indigenous people. We all have our chiefs. This model can work in several places. This isn't a Baltimore thing I'm talking about. Let me stop. Hosea said it best. You want my vision? Here's my vision. If my people called by my name would just humble themselves, humble yourself here. Both parties. I have something to learn from you. You have something to learn from me. But here, Hosea said it best. Talk, preacher. My people are destroyed. Not because of a lack of politicians or researchers or motivation, but from a lack of knowledge. I know something. You know something. Let's work together and build a vision for 2030 to save the least, the lost, and those who lack support. Thank you for giving me a chance to talk. I appreciate it. God bless you.
Pastor King, thank you so much. What a great way to kick off this meeting. Truly inspiring. Sacred spaces, sanctuaries, barbershops. I'm not going to forget your talk, and it is
better not leave out beauty salons now.
Beauty salons, absolutely.
I saw Esther looking at me like, leave that out. That's right. That's right.
Really fantastic way of kicking us off, and I'm sure that your remarks are going to resonate through the breakout sessions and for the rest of the meeting, and I hope you can stay with us and participate as well. So we're going to move in very shortly into our breakout rooms, and we're going to discuss goals for consideration to enhance person-centeredness and inclusivity, and to suggest potential interim actions or milestones. And I want to really focus on that. We want to know what you think we should be doing as an enterprise next to achieve these goals. We're going to have 30 minutes in the breakout groups, then a brief period for each group to report the high-level findings from their discussion. So assign someone to report out soon after you get started. I want to remind all of you to enter your comments in the Q&A box immediately under the webcast window or in clinicaltrials_2030 Slack workspace. Thanks, folks, and I think we'll be moving ourselves into the breakout groups now.